Thank you very much, Nikki. Thank you, Jeff, for your words. Grandfather Vinny for that heartfelt introduction and opening of that conference. You guys are going to get tired of seeing me. So it's my great pleasure to, as Nikki said, introduce the Fraser Mustard awardee for this year. Dr. Fraser Mustard was a pioneer and leader in Canada in recognizing the impact of socioeconomic determinants on human health and development. He was an early champion of the importance of early childhood and the role of communities in promoting healthy development, including advocating for national early childhood developmental programs. A co-founder of the Canadian Institute for Advanced Research, companion of the Order of Canada, the highest level of that recognition, and an inductee into the Canadian Medical Hall of Fame, Dr. Mustard's influence on our field continues to be felt today. Since 2011, KBHN has hosted the Fraser Mustard Lecture at its annual conference in honor of Fraser Mustard's legacy. This year, it's my distinct pleasure to introduce Dr. Peter Rosenbaum as the 2023 Fraser Mustard awardee. Among his many professional accomplishments, Dr. Rosenbaum co-founded the CanChild Center for Childhood Disability Research, now recognized worldwide as a leading center of innovative and groundbreaking childhood disability research. When I asked Peter which aspects of his career he wanted me to highlight in this introduction, because I needed some guidance to pare down the many things I could have chosen from, he identified two other areas. First, being witness to, and I will add, making a major contribution to, the transformation of our field over a decades-long career of research and service on behalf of children and families. Second, and something I share and totally agree with, has been the opportunity to work with and learn from a succession of smart and generous people who have enriched his personal and professional journey. Please join me in welcoming Dr. Peter Rosenbaum to give the 2023 Fraser Mustard Lecture.
Thanks very much, James. This is a singular honor, probably the most important honor I've ever had in this country, because it gives me an opportunity to share many of my obsessions. Forgive me, I did take my medication this morning. This is an opportunity to take, I hope, the next steps in the way that KBHN has been doing for a number of years to create a national program of service for kids and families in a way that I believe would be the envy of the world. And I'm going to try to convince you that we can do that. So I want to talk about, as James said, a very long path in the field of childhood disability, and I like to think of our field as applied child development. And everybody in the room who has ever learned and forgotten the milestones forever will realize how useless milestones are. But the thing about our field that is so important is that we are thinking developmentally. We're thinking about the progress of children through the many stages of their evolution and the evolution of their families. And if we think about it that way, then our field is really, a major focus of our field is child development. And if we understand principles of child development and family development, then we're going to be okay. The other thing I will say, and I'll probably emphasize this a few times, is that the ideas that I want to present today and that inform our thinking really apply to all areas of child health. And it's not true that focusing on typical development will help us thinking about kids whose lives are different. But if we focus, as we're trying to do, on children whose lives challenge us to think about how best to help them, those lessons, those ideas apply to everybody. And that's a message I think we can legitimately, not just arrogantly, but legitimately present to the rest of the field of child health. And I hope that Fraser is listening, and I hope that he'd find these ideas useful. I want to acknowledge formally Olaf and Andrea and Deb and Sam and Gabe Ronan, who formally gave me feedback on these emerging ideas. But these ideas are informed by 50 years of work in the field and by a lot of people, many of them in this room, who aren't being formally acknowledged. So I have 3 ideas that I want to put forward. First of all, that there have been huge strides in our field. I look back 50 years or more, and the field is unrecognizably improved and more exciting than it was when I started my training. And much of that has a Canadian flavor to it, and I'll outline this with respect to concepts that are framing our thinking and reframing our thinking. Operationally, we've got tools and programs that allow us to realize these ideas. Socially, we're engaging with the people who know best, that is families and young people with lived experience. I mean, I was an expert until I started being a pediatrician working with families. And then, as one of my friends who's in the room said to me, "You have textbooks, we have storybooks." An absolutely profound statement about the complementarity between what we bring as professionals with our experience and what families bring with their unique experience and their world expertise on their child and their situation. And we're doing much more collaboration than we've ever done before across traditionally siloed disciplines, and I'll say more about this in a minute. The second thing is that the ideas we're formulating have universal applicability to all areas of child health and development. And this is, I'm going to come back to this at the end because I think we have an obligation, a responsibility to try to get people who teach any area of child health to recognize that we have perspectives, we collectively, including families of course, have perspectives that are useful to everything we do in child health. And thirdly, my argument is that it's time for a Made in Canada national program that brings together the best of what we know and creates something that acknowledges what we know already, knowledge mobilization, implementation of evidence-based programs, and allows people to look at Canada and say, wow, that's a cool way of doing things. And we aren't there yet, but we're very, very close. And I'm going to challenge some of the things that are traditional received wisdom in our field. And if that creates some controversy, that's fine. I'm going to leave time for questions and challenges. And anybody who's threatening to throw things at me, I'll get up on the stage so I'm easier to see. This is not a picture of me as a child. This is Sir Isaac Newton, who, as you will know, talked about standing on the shoulders of giants. And I found this quote by Peter Coy in the New York Times recently, where he was quoting Sheila Iyengar, another Canadian thinker, who said, all successful inventors are strategic copiers who learned from examples of success, extracted the parts that worked well, imagined new ways of using those pieces, and combined them to create something new and meaningful. And that's what we can do. And the slides will go forward. Hopefully, yes. Okay, so I'm going to ask 3 questions. What, so what, and now what? What are the issues? So what? Is anything new? Are we just hearing old ideas packaged differently? And now what? Can we build better? And I think the answer is yes, we can. So what are the issues? We think about children with neurodevelopmental disabilities, and we recognize that we've moved from an obsession with diagnosis, as if that were going to give us all the answers, to being much more interested in how children are becoming, and belonging. How are they evolving? How are their families evolving? How are they becoming part of the community? And how are we empowering them to do that? And I'll give some examples of this in a minute. Well, obviously, a talk about Fraser Mustard has to include a picture of Fraser. I had the pleasure of knowing Fraser. He was the dean at the time that I was recruited to McMaster. He had been the dean for a year, and he was my first dean. And as you know, Fraser, and as James has said, Fraser was passionately interested in children. I will say, slightly frustratingly, that he became interested in children after he was the dean. So we missed that passion at the time that he could have made a big difference to our Department of Pediatrics, but he made a much bigger difference to the field. And he said, if you want an idea of what your economy will look like in the next 20 years, if you want an economy that's vibrant, citizens who are productive, and a workplace that's innovative, think about investing very early in young people. Canada has about 36 or 37 million people, and approximately 20 or 21% of them are under the age of 19. So there's a huge reason to invest in children. And I added at the bottom to remember families. Implicit in Fraser's comments were families. I want to make that explicit, because if we think about 20% of the population being children, and we multiply that by about 4 for the parents and at least one sibling, we're talking about a very, very substantial proportion of the population, and not just that small group of children who have odd things that interest the people in this room in our clinical work. Another really important Canadian voice was Barry Pless, and Barry died just a few months ago at the age of 92. It shows you he didn't have any sticking power. Barry was a pediatric epidemiologist, and in 1975, a mere 48 years ago, published a book with Philip Pinkerton called Chronic Childhood Disorders, Promoting Patterns of Adjustment. And this was not just about neurodisability, this was about the fact that children with chronic conditions have far more in common, as do their families, than is typically recognized from a diagnostic medical point of view. And he was arguing very strongly that we need to see the commonalities beyond the silos. And this remains a challenge. And I'll be commenting on this again in a minute. And he and others, Ruth Stein and her colleagues in New York, produced a lot of evidence to support the conceptual argument that there is much more in common among children with cerebral palsy, autism, Down syndrome, other chronic health conditions than is usually thought about. And this is a message we really need to pay attention to in what we do and how we do it. Two big influences on my thinking were Kenneth Holt, the first professor of developmental pediatrics at least in the UK, and I had the privilege of going for a year and staying for 3, so don't invite me for dinner. And Kenneth was the first person who helped me begin to think about the fact that when we're talking about developmental disabilities, the first word is actually quite important. And we've typically not paid attention to the first word. What do we mean by developmental disabilities? We mean conditions that either do or are likely to have an impact on a child's developmental trajectory. And I will argue very strenuously that what our field is about really is about understanding the impact on development of children who have chronic health conditions, not just neurodisabilities. What does this mean for how they engage, how they're able to engage, how they have social opportunities, and so on? And this was really a profoundly important idea for me, although it took the idea a long time to germinate. I put Christy Brown in here because for those of you who have seen the film, many years ago, Daniel Day-Lewis did a superb job of being Christy Brown with cerebral palsy. Christy was born in 1932, and at the age of 22, published a book called My Left Foot. How many people here have published a book at the age of 22 and have cerebral palsy? It's a remarkable book. Oh, look at this. Isn't this nice? Thank you. Okay, so I can now... now I got to do two things. Nope.
Gotta do one.
Oh, okay. Hey, this is really great. Thank you.
All right.
Yep.
Okay.
Thank you. This, thank you. Christy, at the age of 20, he was the 10th or 11th of 20 children in the family. So how many people here have had 20 children? Right. So his mother was a busy lady, and he had cerebral palsy and was thought to be really profoundly impaired in every respect, except his mother, who was a very astute observer, recognized that he had abilities that had not been seen by other people, and he was able to use his left foot to write and eventually to paint, and became a very eminent author, who, among other things, published this book when he was 22 in 1954, and it was an account, a wonderful and entertaining account and distressing account of his life over the first 22 years of his being. And I wrote an essay recently, having read the book and presented it at a book club. I wrote an essay about the lessons that were there under our noses, under their noses in 1954, lessons that weren't seen. It was all there. He was describing the importance of family, the importance of engagement, the importance of being able to do things with his brothers who were very creative with him, and how when the wagon in which they took him out broke, he was confined. And it's a profoundly important message for all of us. I'm not going to be modest about CanChild because I think we've had the opportunity through a good deal of good luck to engage with families right from the beginning. Our name, CanChild, was coined by a parent. So there. We've been working in family-centered service right from the beginning with families. We've created unique tools that are used all over the world. We have done some work with the F words, and I'll show this a little bit because it's probably our most important contribution. We've been engaging with systems and the education system and the Partnering for Change program that Cheryl Masuna started and that Winona Campbell and her group are managing now is a very active engagement with the boards of education, looking at ways of providing services to inform teachers and others in the school system about the needs and ways to help kids with impairments without doing the traditional take them out of the class and give them therapy. And this is a very, very successful program that's now been funded very substantially over several years. We have, and again I'll refer briefly to it, a very strong working relationship with the Ontario Ministry of Children, Community and Social Services. We've done a lot of work with the preschool speech and language program and had access to data on 80,000 children with speech and language services. And my colleague BJ Cunningham wrote her whole PhD thesis on analyses of these data, which probably otherwise would have sat in a computer somewhere. And these are very comfortable and bi-directional relationships. And now we've got a program going on with Australia called Envisage, which is having a big impact. And so there are things that we're doing in Canada that other people should know about. I hope that everybody in this room knows about the F words. We wrote a paper, Jan Willem Gorter and I wrote a paper just for fun in 2011. It was published in 2012, and it's called The F Words in Childhood Disability. I swear this is how we should think. And this was the paper written on the basis of some slides that we'd put together for a talk I'd been asked to give in the UK. And this was just for fun. We had been trying to bring the World Health Organization's framework for health to life, and we'd been talking about these ideas a little bit, and we just did it. And this thing's just gone viral. It's quite crazy how much of an impact these ideas have had. And as you see, there are at least 35 languages in which these ideas are available now. And now we call these the F words for child development. We worked in, and this is a good example of what I said at the beginning, we worked in and work in the field of childhood disability. So the F words in childhood disability seemed the natural starting point. But then colleagues in our own group, as well as people outside, said, this isn't just for disability. This is for all child development. And increasingly, this is for human development. And we have people who are working to animate these ideas in the adult field as well. So this is what the F words look like. And the F words are simply a tongue-in-cheek way of helping people to remember the World Health Organization's framework for health. So we talk about fitness, mental health, and physical fitness, which are often, physical fitness in particular, is often less good in children who have complicated lives. We talk about functioning, and it doesn't matter how you do it. How many people in this room are wearing glasses? We don't fuss about that, but if this was a room full of people using wheelchairs, we'd say, wow, isn't that amazing? That's ridiculous. We talk about friendships and the importance of social relationships, especially for kids. With respect to fun, we want to emphasize what it is that's unique about this child, what makes their life interesting, and how can we take advantage of that to enhance their lives with what we might call therapy, without making therapy a burden. And family factors, we emphasize this because the obvious essential environment for children is family. So fitness, we still want the best of therapies. We're not saying throw anything away. We are challenging people to think about what they're doing and why they're doing it. So doing therapy for its own sake is not a good answer. Doing therapy that will enhance people's aspects and functioning and fun and so on is important. With respect to family, we want to talk about the social determinants of health, and you heard that that was one of the animating forces for Fraser. We also want to be family-centered, and that's easy to say, but still there are lots of people who are saying, you know, be reasonable, do it my way. And we obsess when families are not compliant, which is incredibly arrogant. With respect to fun and friendships, we want to know about the individual and not just about the case, not just about the diagnosis. And this is, I think, the best version of this framework, which brings together the ICF ideas, which are in the smaller boxes, and the same colored boxes with the F words, show how we're trying to link these ideas. And this framework in various forms is now used in many, many languages, and people are increasingly translating not just the words and the concepts, but also the graphics to reflect the cultural variation around the world, and there's lots more work to be done on that. We added the word future, although it is not part of the ICF. The ICF is a slice-in-time picture of you today, or your situation today. But Jan Willem and I felt it was really important to remind people that we're talking about children, we're talking about families, we're talking about a work in progress. So what are some of the modern issues? Well, just look at the program here and see these are 3 examples of things that are in this program in these 2 days. Thinking beyond the diagnosis. There's a session after this one on 21st century philosophies for developmental disability, promoting development of children and families, and James alluded to the AFCA program last night. That is another session that's on today. Taking an ecological view of child in family and community, and recognizing that beyond my fantastic clinic room, there's actually a life at home and in the community. And we're increasingly paying attention to that. Other modern ideas, focusing on functioning, getting away from the idea of normal, which is a tyrannical idea, and we've got to get rid of it altogether. Getting past the idea that therapy should fix things. We don't fix very much in medicine. And I don't just mean doctoring, I mean in all of what we do. We don't fix very much. And that's not a rude comment, it's a statement of the obvious. Focusing on diversity and acceptance of variation in how people do things. We now talk about neurodiversity in a way we didn't used to. And very importantly, taking a life course approach. There are at least 3 times as many adults with autism, cerebral palsy, Down syndrome, blindness, and so on, as there are children. Oh my God, what's that about? Well, what it's about is that they don't all get better when they turn 18, and they don't all disappear when they turn 18. And it's long overdue for us to pay attention to a life course thinking, and that has implications for what we're doing with 2-year-olds and 3-year-olds, as well as what we're doing with 32-year-olds and 52-year-olds. KBHN's foci, as you know, are a vision of children living with neurodisabilities, enjoying a good quality of life, inclusion in all aspects of society, and reaching their full potential. And the mission, as is being realized incredibly well, is to catalyze collective action across sectors and to ensure optimal care and better outcomes for children with neurodevelopmental disabilities and their families. And the "and their families" is essential because we're not just talking about kids. I've been doing this work since I started my training in 1970. I have never, ever had a 3-year-old come into clinic on her own and say, "Doc, you gotta help me. My behavior sucks and I don't talk good." I mean, it is a statement of the obvious that we have to be interested in children, in families rather. So is anything new? Well, many people may be rolling their eyes. The lights are in my face, so I can't see whether you're doing that. But the reality is that while these ideas may make sense and may be understandable, they aren't necessarily being used. And so don't we know this? Yes. But we talk the talk, but we don't always walk the walk. And my wife talks about the world of hyphenated phrases: family-centered, evidence-based, life course, function-focused. These, I mean, who's going to argue with any of these? These all make sense. But when we look around, and I was hearing this morning from one of my colleagues, who I won't embarrass by identifying her, but she's quite tall and comes from Montreal, and won an award last night. There are still places in our own country where these ideas are not being put into practice. So there's a lot of work to do, and we have the tools and the ideas to do it. Now, let me be particularly provocative and say that in March of this year, many of you will know that Bill S-203, the Federal Framework on Autism Spectrum Disorder Act, received royal assent. This legislation outlines a commitment for the development of a federal framework designed to support autistic people, their families, and caregivers. The good news is that a major neurodevelopmental condition has been recognized at a federal level. But it occurred to me to imagine that if a federal framework on Prostate Cancer Act had been passed, there'd be all hell to pay. Because prostate cancer, as important as it is, happens to only half the world. And prostate cancer is is an example of a huge number of kinds of cancers that affect people across the spectrum of age and gender and so on, and their families. And this is not a comment on autism. This is not a critical comment on autism. I know that autism can often be a very challenging way for people to experience the world, a challenge for their families, a challenge for the community. And so the fact that the government has recognized this is really important. But that's really only part of the story. And I think we have a challenge to get them to recognize that there's more to the story than one particular kind of neurodisability. And I think this balkanized approach to child neurodisability is inequitable. I don't think anybody means to be inequitable. I don't think any of this was done deliberately, but I think it was not as wide a scope as it could have been and should have been and can be and hopefully will be. So we need to see the whole picture of child onset neurodisabilities and bring everyone into the tent. And I think that these ideas have been around for a long time, but we're still not seeing them, or at least we're still not acting on them. And we tolerate and sometimes promote what amounts to competition. And I'm going to say more about this in a minute, because I think there's a huge amount of unintended competition. I don't think any of us wants to be better than anybody else, but if we're all competing for the same funding, for the same attention, we're trying to get the ear of the government or whoever, and we show up day after day after day, people are going to wonder what the hell's going on. So the question, of course, is the pot finite? And I finally, when I got to the age of 60 or something, began to recognize that that was probably true. I'd never wanted to accept it before. But because the pot is finite, we can't afford to take this fragmented approach. If your program needs to have an infrastructure, and mine does, and James's does, that's 3 infrastructures. That's nuts. If we were imaginative and creative about pooling the best of our ideas and resources, we could create a whole that was much greater than the sum of the parts. And we could probably impress donors, because people would see that we are actually working together collectively on the same road, in the same direction, with complementary skills and efforts. And this would be a message to people who are still thinking categorically. And many people are, not because they're not smart, but because they don't come to conferences like this. And I don't go to policymaker conferences. And so we exist in parallel tracks, and we've got to try to bring the parallel lines together. People ask, don't you people talk to one another? And it's a legitimate question. You know, so-and-so was here yesterday telling me the same story. Why are you here today? Don't you know what they're doing? Well, I know what they're doing, but we're not working together. And there are too many competitors wasting our time and our talent and our opportunities. And one of the things I found incredibly exciting about Saturday and Sunday, just looking in from the outside, was seeing a huge room full of young people all in the same space working together. And this is something that KBHN has achieved that I don't think anybody else in our country has ever been able to do. And this is incredibly exciting. And James alluded to this, and I would just remind people, or perhaps it was Nikki, who talked about Fraser creating the Canadian Institute for Advanced Research and the Founders Network. This is a model of how we could be doing things together, collaboratively. So where do we go from here? Now what? Clearly, you know what my message is, which is to create and implement and realize a made-in-Canada approach to applied child and family development. I think that Canada, and what I mean by Canada remains to be seen. I don't know if there are any policymakers here. If you are here, please don't raise your hand, because you'll be in trouble. We can develop, promote, support, implement, and realize a national child development program with federal government endorsement and sustained funding. And I'm convinced that this investment, along the lines of what Fraser talked about a long time ago, this investment would repay enormous dividends, although I am not primarily interested in the economic benefit. If families were well supported, if kids were well supported, they would probably be demanding less of us than they are now, because the systems were integrated and we were doing things in a cool way. And this would help families too. There's a huge burden of physical and mental health distress in families raising kids with complicated lives. And I believe that a lot of that is preventable. And a national program of the sort that I'm imagining would contribute to that prevention. So we need a Canadian, made-in-Canada national program. And I talk about children with complicated lives and have used this phrase for years and had a lot of pushback. And I push back at the pushback by saying that my wife and I, have 3 terrific former children. Well, they're still our children. They're adults now, and their lives were extremely busy with sports and music and 1,000 other things, all of which were things we wanted to do and were prepared to stop doing other things and support them to do that because they were important to the kids and to us. What I mean by a complicated life is a situation where parents, by virtue of a child's impairment, physical, mental, developmental, are forced to do things they wouldn't ordinarily have to do. None of our kids had to deal with the healthcare system on an ongoing basis, or the special education system, or the recreation system, or the government policymakers. So complicated in this context is situations that happen not because we want them to, but despite our best intentions. And I think we need to recognize that families with complicated lives need systems that will support them. Integrated systems. I've already argued that there are a lot of strong parts, and I haven't talked about all of them by any means, but we now need to create a whole that is greater than the sum of the parts. And I think it needs to be built, first of all, on a philosophy that I'm going to state some things I've said already, but I want to emphasize these because I think they're fundamentally important, that family is the unit of interest. Of course, we're interested in the children, but again, the children don't show up on their own. Family caregivers are the people we should be concerned about, as well as their children. Focus on development. You've heard me say this several times, and development of the family as well. Anybody here who's a parent knows that you're parenting your 5-year-old differently than you parented your 2-year-old, because your 5-year-old is dragging you along, and parenting is a dance led by the children. And as the children learn to dance differently, we have to keep up with them. So we parents are constantly changing. We need an ecological perspective that recognizes that children live in families and families live in communities. And we want to support the engagement of child and family in their community in ways that are important to them. The importance of equity, diversity, and inclusion. These are all extremely important. And again, we're talking about neurodisability, but we're also talking about neurodiversity. Focus on human functioning. Jerome Bickenbach, who's another Canadian, refers to human functioning sciences, something we don't teach very well. I was a resident at a famous children's hospital in a big city near here and never learned anything about children and child development. I learned about diseases. I didn't learn anything about families. And sadly, at McMaster in 2023, we're not doing a whole lot better. We're not teaching child development. We're not teaching about families in ways that we could do to enhance the understanding of our trainees about the realities of children beyond their disease conditions. We need to focus on participation and engagement in life in ways that are meaningful to that person, however they do it. And we need to think about a lifespan approach and not just to think about children, because children become adults. We have lots of programs and lots of practices that we could be using, and many of which we are using. I'm arguing that we apply the best of validated, impactful concepts and frameworks. And I'm arrogantly arguing, but with evidence to support the arrogance, that the ICF framework and the CanChild's animation of these ideas are ways that are having a transformative impact around the world. We know that. We have good evidence of that. And this is happening across cultures, across languages. These are non-denominational concepts, and they're not grounded in one particular language or culture. We need to think and act non-categorically to get past the diagnosis. The diagnosis is important, and I'm not saying don't do it. I'm just saying let's not stop when we find a diagnosis, and let's not just be on an odyssey to get the exact specific diagnosis. We can do that while also offering services, advice, and engagement. We need integrated services across the lifespan. One of the metaphors that I've heard in several countries is that when our kids turn whatever age it is, 16 or 18, they fall off the cliff. And that's an interesting metaphor in different countries, but it's the same metaphor, that the world for adults with child onset disabilities is a very sad and sparse world, because we're good at rehabilitation when people have a stroke or motor vehicle accident, but we don't know what to do with people who've grown up with a different life experience. And their needs are not particularly, and certainly not solely, medical. David, Nicholas, and Lucy Locke's system navigation work has been funded for a number of years and supported by KBHN, and is an example of an approach that we could be taking and should be taking across the country. And I've already talked about how important it is, I believe, to train child health specialists in all of these concepts without sacrificing their understanding of the diseases and the management of diseases and the evolution of our understanding of diseases. But these seem to me to be generic concepts that should be mother's milk to all our trainees, and they're not systematically. So we need to train people who work in our field to think about human development. We need to teach about family as the unit of interest and recognize that the impact of any health condition, any chronic health condition on the family is enormous, and that we should be paying as much attention to that as we are to the child. And quite frankly, if we spent more time thinking about the impact on the child, on the family rather, that would have an impact on the parents and on the child's development. And there are ways to do this. And again, I come back to the World Health Organization's International Classification of Functioning framework, which brings these ideas together. Instead of saying, oh, well, that's fine, that's for the social worker, or that's for the this, or that's for the that. This is all an integrated program. It doesn't mean that all of us have to do all of the things, but our programs have to do all of these things together. So we need national policies. And the roles of policymakers are still not as rich as they could be, and not as engaged as they could be, and that's probably a good deal our fault. We can't expect people by telepathy to understand what we're saying, but we have an opportunity to do knowledge translation, to share these ideas, not to wag a finger at people and say, boy, are you dumb, but to say, you know, there's some cool new ideas around. And here's what the ideas are, and here's how they might influence your program. I mentioned earlier that our work with the Ministry of Children, Community and Social Services in Ontario, at their request, was to know more about the F words and to know more about some of the tools we've created. And the ministry has engaged us to create tools to make these ideas available, and these tools and these ideas are now part of the fabric of their programs. Now, we didn't go and beat them up, and they didn't come and beat us up, but we'd had conversations with them over the years. We drank a lot of coffee and talked together about these ideas. And the same thing is happening with the BC government and the Ministry of Children and Family Development. They're approaching us. So it is possible for these things to happen, and we need to do a good job at it. I would love to see us have a program that trains family physicians who are interested to become specialists in disability across the lifespan. And I'd love to claim ownership of this idea, but it's not mine. It's an idea I heard in 1980 at a meeting in Boston, where a woman got up in the context of a symposium on childhood disability and adults, the needs of adults, and she identified herself as one of 4 physicians, family physicians in the United States who had a full-time practice in disability. And that's a really cool idea, because the needs of adults with child onset conditions are not primarily medical, but they need health care. And it's so easy for them to be referred to the specialist for spines or left hips or whatever, and for people to miss the woods for the trees. And this would be a really interesting program. And I think Queen's has a small program in this way, but there's much more to be done. I think these ideas need to be a basic science in the education and training of everybody who works with kids and families, and a universal aspect of all components of child health. And here's the punchline, no pressure. I think KBHN is clearly poised to lead this initiative. It's already doing a good deal of that. We need an honest broker, national leader. Australia has a Department of Social Services, and they are currently funding sadly only for Australia at this point, our Envisage for Families program. This is a program that a parent has referred to as early intervention for parents. And we have good evidence from the work we've done so far in Canada and Australia that this program has a big impact on parents of children with neurodisabilities in terms of their sense of empowerment, their sense of confidence and competence in parenting their children. But this is still a program that is available only through research grants and is not yet funded in this country to be available to people. The Australian government gave they awarded $6.9 million to our colleagues in Australia who are rolling this program out to 2,000 families across Australia, and we need to catch up to them. We always, always, always need to engage families and people with lived experience, as we're doing in the Envisage program. The Envisage program was developed from the get-go with parents and researchers and service providers. And when parents like it and say, boy, you guys are doing good stuff, we say, of course we are. It's parents like you who told us what to do. And that's really important. And of course, we always, as James said last night, we need to have targeted goals and deliverables and evaluate our programs and not just do them because they sound like a nice idea and they're the flavor of the decade. Our goal then, I believe, should be to create a Canadian National Child Development Program as the standard for the world of childhood disability, for people to be coming and saying, how are you doing this? And what are you doing? And what are the ingredients of it? And how can we do it in our country? And I don't know of any place that does this as well as it could be done, and as well as I believe we could do it. So I'll end with what Peter Coy said about successful inventors being strategic copiers. And you'll see that I'm suggesting that we take bits and pieces, some of which we've created and some of which other people have created, and learn from the examples of success, extract the parts that work, imagine new ways of using those pieces, and combine them to create something new and meaningful and unique. I think the time is ripe. I thank you for listening. I'd be happy to have some questions and comments and challenges in particular. Thank you very much for this honor.
So we do have a few minutes. If there are some questions for Peter, there's a lot of ideas that were put here. Annette.
Hello.
We have a mic on the way, Annette.
So first, I want to take this opportunity to thank you, Peter, for the enormous contributions you've made to the field, and importantly, all the trainees and people you've mentored that have had an enormous trickle effect in terms of impact to the field of childhood disability. So big thanks.
Thank you.
So we have a small country in terms of numbers, but very rich expertise in the field of childhood disability and child development. Yet, our performance in child health is very poor. If we look at the UNICEF report that we rank 30th out of 38 rich countries in child health. So how can we do better? What's the, there is a very important gap, like we're into implementation, but this knowledge to policy seems to be, I so support the next steps that are needed, but how do we get there in ways that are going to be meaningful?
Well, I will reiterate a bit of what I said. If we were to focus in the field that is drawing us together in this room on so-called childhood disability and articulate and begin to operationalize a clear well-integrated program, we will have, as we occasionally do, people from other areas saying, what are you guys doing in the childhood disability area that we could be doing, as you have done for many years, in the cardiac clinic, in the neonatal follow-up program, in the pediatric intensive care program for after PICU care. What are the implications for the kids who have chronic renal conditions or metabolic disorders that aren't necessarily neurodevelopmental in impact, but which are seen often much more as medical issues, medical puzzles to be solved, and without recognizing the impact on the rest of the child and family. In 1962, there was a paper published by Bergman and Stamm on cardiac non-disease. And the paper talked about the impact on kids and families of the advice that kids were being given, the parents were being given about their kid if their kid had a heart murmur. The heart murmur was equated to heart disease, and children were restricted from being active. The same thing is happening, and you'll know this from your spouse. The same thing happens in kids with epilepsy, who are often constrained in what they're allowed to do. If we thought about the impact of the health condition on kids across the whole spectrum, we would be thinking differently and acting differently. And I come back to the original premise of the talk, which is that our field is positioned to look at the most unusual and complex circumstances of neurodisability and extract messages which I think can be applied to everybody. And that's our challenge. Yeah.
I'll wait for the microphone, although I can also talk about it. Really appreciate the talk, and some of the things that I really appreciated was that articulation that what we can do in this field really impacts all child health. But you also articulated something which I've been kind of joking about, the ways in which policy and kind of research and implementation are often engaged more in parallel play than anything else. So can you talk a little bit about how CanChild might be bridging that gap, or how organizations or clinicians can kind of articulate to some of those policymakers and decision makers to do a better job of right-sizing the kind of child health continuum?
Yeah, well, I think before you get as old as I am, I need to reflect on how I used to have a lot of righteous indignation about how everybody could be so stupid and not understand what we were thinking. And of course, telepathic communication doesn't work, at least doesn't work very well for me. And so the policymakers, don't know what we're thinking and what we're doing. But if we were sit down, as I said, sit down with them and just not go and ask for anything, but just say, listen, there's some cool stuff happening that you might be interested in. Let us tell you about it. And this is one of the ways that the F words ideas happened, was that Jane Cleave, a senior senior civil servant in the Ministry of Children, Community, and Social Services, and I had met at conferences, and we had just published the F words paper, and this was in the autumn of 2011. And she said, what are you working on now? So I said, well, we just had some fun with this. And she said, and this is literally over coffee at this conference, she said, would you come and talk to our division about it? And she said, oh, by the way, every month, the deputy ministers of health, education, social services, and one other ministry get together for coffee. Come and talk to them. And, we didn't have to beat down the door, but we had this conversation with somebody we knew, and boom, off this began. The same thing happened with our engagement with the ministry, with the preschool speech and language program, which sees about 80,000 kids a year in Ontario. And one of my colleagues, Nancy Thomas-Stenell, had created a very, very good measure called the Focus, which was being promoted for use in preschool speech and language programs. And we had conversations with them, and again, we were invited to come and present at their tables. And then when they started collecting data, we said, well, could we help you with the analysis of these data? And they said, sure. And we got access to 80,000 records, which BJ then was able to analyze up, down, and sideways and report, not only so that she could get a PhD, but so the program could learn a whole lot that they probably would never have learned because they didn't have the capacity to do that. This is not being rudely critical. This is being analytic about the possibilities of sharing ideas, of building bridges between the things that we're interested in and can do and how we're thinking and how the field is changing. That's the most important part of all, how the field is changing and how it is in their interests to do things differently and, I believe, more effectively and more efficiently. So there's the challenge to everybody: is find your policymaker, your local champions, and just have coffee with them and say, look, there's some cool stuff happening. You might be interested in it. We're not forcing them to do anything, but they will value learning about what's going on because they don't read our journals any more than we read their journals, or at least I certainly don't. And
Sorry, I'm gonna have to.
yeah.
So, don't go away. So I don't get in trouble with the organizers and get us off time. I'm going to have to close the session. Peter, I hope you'll stick around at least for coffee. And I'm
2 days?
For 2 days, absolutely. That's perfect. There are lots of people, I'm sure, that would like to engage with you in these. So you reminded me of something I thought, our very first meeting of investigators back in 2009, or early 2010, sorry. We brought the different groups together, and I thought at that time we were going to learn more about the individual disabilities that our various groups were studying by working together than we ever would if we had stayed siloed and apart. And another thing you just said, and this, I was reminded of this the other day, that some research we've done with a community that we went back and showed them and got their permission to publish. They said, this is very important. What's your plan for getting this message into the hands of decision makers who will use it? And that challenge is something that I thought, oh, how are we going to do that? Yeah. So it is our role, it is our job to make sure that knowledge that we generate actually moves forward and has the impact that we want it to. So at this time, I'd like to invite Jeff Berdella back to the stage to thank Peter on behalf of the network, and of course we have a few mementos to express our appreciation for your talk. Jeff.
Thank you.
Thank you, James, and thank you, Professor Rosenbaum, for a very inspiring speech. It awakened for me work that I did previously with policymakers in 2 different levels of government, and work primarily prior to joining KBHN focused on supports and services for adults with developmental disabilities, and your concept of this odd, awkward cliff from 18 to 19 also happens from 65 to 66. And, you know, I think part of the message to our policymakers is that this artifice of chronology, when we talk about these children and Canadians with developmental disabilities and challenges, that let's focus on what supports and services the person needs as opposed to what it happens to say by way of their birth certificate, because levels of development and maturity are highly relative. So thank you for helping me connect some of those dots. So my job here really is to say what a privilege and an extraordinary moment this is, to share a stage with a giant who, as you said, stands on the shoulders of giants, and who I'd like to say will be the shoulders upon which future giants will stand. So thank you very much for that. And on behalf of KBHN, I'd like to present you with the 2023 KBHN Fraser Mustard Award. Your obvious dedication embodies the legacy of Dr. Mustard, and we're inspired by your words and actions to effect change in the fields of childhood disability, family-centered service, family well-being, and families of children with complex lives. So thank you very much.
Thank you, sir. Thank you. Oh, wow.
Yes, I understand you were asked what your favorite
Yeah.
animal was.
Now, is Ben here?
Yes. The artist?
I want to meet Ben. I'll meet him after, but yeah.
Step out here for a photo.
Yeah. Which would you care to hold, or both, or do you want to juggle? There.
Thank you.
Ben.
I want a picture with Ben. Thank you.
Thank you very much.
This is really wonderful.
Yes, that's a red fox.
Ben, come a little closer for me. Just over. Okay,
Yeah.
come up here. Good. Right
Hey.
there. Okay, looking at me. Yay. Good job, Ben.
Thank you so much.
Well, that brings this opening session to a close. Thank you again, Peter, for your thoughts, your challenges, your history lessons. I hesitate to accept your challenge for KBHN to be a national leader on behalf of the network. But I think knowing what we have thought about and planned for the future, I think the network embraces the opportunity to become that voice and carry this message and this cause forward. So that closes this session. We'll have a short break, and then we move into the first concurrent sessions. Please consult your program. At least one of the sessions will be in here, but the others will be in other rooms that are close by. So enjoy the conversation with colleagues, new friends, and we'll continue to learn together. Thank you.